I would request Dr. Alsy and Dr. Sam to please limit your presentations to 8 minutes.
Topic of my presentation is getting on my nerves. So I'm presenting a 51-year-old businessman from West Bengal. He presented with purpuric lesions in bilateral lower limb for 1 month, swelling of all four limbs followed by weakness for 10 days, and burning sensation of all four limbs, distal more than proximal. History of presenting complaint: he was apparently well till 1 month back when he developed these lesions in the extremities, followed by swelling of the all four limbs associated with weakness and burning sensation of the four limbs. Past history wise, he had reactive airway disease, who was given immunotherapy, and 6 years back he had history of allergic skin disease. He is a known case of hypertension for the past 4 years. Examination wise, his vitals were stable. Pulse rate was 80, BP was 120 by 70, respiratory was 20, and he was afebrile. Systemic examination, CNS, the positive findings that were fine touch and vibration were lost in both foot and hand. Joint position sense was lost till ankle. There was reduced power in elbow, wrist, ankle, weak hand grip bilaterally, and weak extensor hallucis bilaterally. Reflexes were absent in all four limbs, and rest of the systemic examination was normal. So, sorry, ma'am. Absent deep tendon reflexes were absent. So summarizing, it's a 51-year-old gentleman with subacute history of new onset weakness, with sensory loss of all four limbs, distal more than proximal, with the background history of reactive airway disease, and examination findings of rashes and bilateral feet, loss of joint position sense, vibration sense in the foot and hand. We were also thinking in same lines. So we consider the differentials as autoimmune could be a GPS because it was almost a rapid onset from distal to proximal, and vasculitis probably EGPA, granulomatosis with polyangiitis, microscopic polyangiitis, or a toxin-induced neuropathy, lead, arsenic, mercury, or poisoning, or a miscellaneous any retroviral infections, hepatitis B or C, or a paraneoplastic polyneuropathy. So investigation wise, his hemoglobin was 12.2 with MCV of 74.9 and RDW of 21. Total counts of 34,700 with 67% eosinophils in the peripheral smear. Electrolytes are 129, 4.4. Sodium was 129, potassium was 4.4, and bicarbonate 25. His creat was normal. Liver function had shown mild elevated liver enzymes. So for the next workup, his CSR, CRP inflammatory markers were elevated. His anti-MPOP ANCA was elevated. It was 173. His ANA was negative. IgG was 1405. So because he had bilateral absent reflexes with absent joint position vibration, we have done ENG-NC, which shown bilateral severe sensory motor axonal polyneuropathy, and a nerve biopsy had showed significant perivascular infiltrates of eosinophils and lymphocytes. His heavy metal screening was negative. BBVS was negative, and CT thorax abdomen had shown bilateral ground glass opacities in the posterior basal segment. And for the malignancy workup, his bone marrow was showed modulatory hypercellular marrow with markedly increase in eosinophils and precursors, but no abnormal cells. So our final diagnosis that we have come into based on the investigation, history, and examination was eosinophilic granulomatosis with polyangiitis, anti-MPO positive with peripheral eosinophilia, eosinophilic marrow infiltration, reactive airway disease, myocarditis, subnephrotic range, proteinuria, and peripheral neuropathy. So I'll be talking about EGPA and just the treatment part of it. So as we know, EGPA is a multi-system disease with necrotizing ANCA-associated vasculitis affecting both small and medium vessel characterized by asthma and eosinophilia. So this is the 2020-22 classification criteria for eosinophilic granulomatosis, where there is a clinical as well as lab criteria. Clinical includes obstructive airway disease, nasal polyps, and mononeuritis multiplex, which carries 3 and 1 points. And in lab, if there is a anti-PR3 antibody positive, that would reduce the score by 3 and hematuria by 1. The score more than or equal to 6 was classified as eosinophilic granulomatous with polyangiitis. Pathophysiology wise, it is considered it is a helper 2 T cell associated disease where T2, the helper T1 and 7 cells activate IL2 interferon gamma, IL-17, causing granuloma formation, thus tissue damage. And IL-4, 5, 13 will cause B cell activation, thus causing IgE, IgE4 and ANCA, thus deposition of the immune complexes, causing tissue damage, as well as etotaxin associated guidance of eosinophilia to the peripheries and release of the toxins, eosinophilic derived neurotoxin, major basic protein, and eosinophilic cationic protein, again causing tissue damage. I'll briefly go to the treatment guidelines by ACR-OLA 2020-22. So they have there is an induction period and maintenance period. So induction, it is based on the severity of the disease. So if it is a life-threatening disease or a non-severe disease. So if the patient has glomerulonephritis, pulmonary hemorrhage, meningeal CNS involvement, cardiac involvement, GI involvement, it is considered as a severe disease. Whereas if they have a nasal paranasal disease, skin involvement, myositis, non-cavitating pulmonary nodules or episcleritis is considered as a non-severe disease. So severe disease, we straight away, for non-severe disease, we give mepolizumab with glucocorticoids, and whereas for active disease, we give glucocorticoids plus cyclophosphamide or ether rituximab. So pulse is ether methyl prednisolone pulse. Pulse with methyl prednisolone. So in the intensive, in the maintenance phase, we can give either azathioprine, methotrexate, or MMF. So in our patient, we have given methyl prednisolone 1 gram pulse for 3 days after deworming and a normal chest X-ray, followed by 1 mg per kg prednisolone, and the induction maintenance regimen of injection cyclophosphamide 15 mg per kg. As a second line agent, we have planned for azathioprine, We also provided physiotherapy as well as occupational therapy. This is another aspect of a study that was done in Japan, which was published in February 2022. So this was about a lady who was diagnosed as EGPA, and was started on steroids and tapered. However, paresthesia continued to persist, and she was started on memalisumab, and her paresthesia improved. The clinical improvement of her symptoms as well as EMG-NCV showed improvement in the conduction study. So take home point is, it's a necrovasculitis with eosinophilia. It's an ANCA-associated vasculitis with asthma and multi-system involvement, predominantly lungs. And for active non-severe disease, mepolizumab with glucocorticoids we give as first line, and for severe disease, glucocorticoids and cyclophosphamide or rituximab. And for maintenance, you can either give methotrexate, azathioprine, or MMF. And in this mepolizumab, introduction of mepolizumab can be combined with prednisolone, might give a improved treatment for the peripheral neuropathy.
Do we have mepolizumab here? Why did you say azathioprine for this? What is the age of the patient?
Our patient was 51-year-old.
Is he from local?
He is from far away, Bangladesh.
From where?
Bangladesh.
No, the things that you take into consideration. There is a vascular score which can be used. We use it more for beginners than for shell straws, but it can be used to any of the vasculitis. Kind of gives you a score to kind of say how are they doing overall. Are they limiting? Are they getting better? But that's more for beginners. Shell straws, I don't know if it has a similar score. That's one way to kind of follow up. The second point is that if you are somebody who's got severe, which is myocarditis, you said peripheral neuropathy, it seems to be quite extensive. In which case, I would do something more stronger, like MMF if money is not an issue, or methotrexate rather than azoran. Because we tend to see azoran is a little milder compared to the other two. I don't know if there are studies which compare between the two. Most of the guidelines would say one versus the other, but azoran, maybe situations that I would consider azoran is where they are so far off that they can't monitor or they can't come back if there is a problem. Second is probably where pregnancy is being planned, young person, maybe we still give some immune suppression. Those are probably a couple of situations that I think give azoran and ask them to monitor counts. But otherwise, I would kind of prefer to do something a little stronger rather than azoran. That's just what, because this patient has myocarditis. The third issue is when you say deep tendon reflexes are lost, you're talking about biceps, triceps, looking at your supine knee and that. If that is lost, you can actually do deltoid. You can actually do pectoralis. So there are other reflexes, triceps. So it's good to specify what reflexes you checked and how many are lost, rather than say deep tendon reflexes are lost. Doesn't make sense.
Thank you, Dr. Alsy. You want to just tell what was the indication for pulsing in this particular patient? What was the severe organ involvement that caused us to pulse the patient? Yeah,
It was she had a polyneuropathy that was
okay. There is severe mononeuritis multiplex, and there was features of myocarditis also. Okay. What duration are you planning the remission maintenance phase?
For cyclophosphamide for 6 doses, followed by azathioprine for about 12 to 24 months is what planned as of now.
Sure. Yeah, and patients who have recurrent repeated relapses might even require longer therapy than that. Okay. Thank you, Dr. Alsy. We'll move on to the last presentation for today.